Good morning, everybody. I hope you guys can hear me. We are actually going to start at 9:10 so we can allow everybody to join, okay? All right, good morning, ladies and gentlemen. Do we have anybody on our cell phone today? Anybody, and can you also hear me? Yes, no, maybe.
Hear you.
Okay, super, thank you so much. All right, anybody on their cell phone? And if you are, can you just type your name or just say your name? That would be great. We're gonna give everybody 3 minutes. Let's see if they decide to show up. Okay, good morning, ladies and gentlemen. We're starting 1 minute early, but I think everybody who is ready will be able to trickle in. So good morning, welcome to week 2. We are moving right along. You guys did amazing on submitting your assignments this week, so thank you very much. Grades for every assignment are going to actually be uploaded no later than Sunday of the week that they've turned in. So we have a week to grade them. These ones are kind of very simple to grade. All I ask is that you turn in your assignments on time. You'll get feedback individualized. If it's a super easy assignment, then you'll get a grade. And this one was pretty simple and pretty straightforward. So anticipate that being updated and uploaded by the end of the week, and we should be good to go. As far as the way this course, our class setup for today is going to be, what we're going to do is we're going to just do a little bit of housekeeping regarding our assignment that is going to be due on Sunday, this Sunday of this week, which is going to be the 17th before 11:59 p.m. Then we're going to do a review, which is going to review week 1 material, and that's going to be in the form of a Kahoot. So hint, hint for the Kahoot questions and concepts. If you understand them and you kind of like go over them, it will tremendously benefit you. In addition to that, we're going to finish up our lecture from last week, and we're going to go through chapter 2, which is immunity, so cell or immunity in general, and then we should be caught up. And next week will be our last week before we have our exam, which is crazy. Exam 1 is already on the horizon, but yeah, we're moving right along. If there are any questions or comments, please do let me know. We are going to make a transition probably shortly after our first exam. Just let everything be baseline, providing that Teams is working well and it's functioning. I've had a little bit of, actually quite a bit of technical difficulty with it, so we'll see how that goes. Okay, if there are no questions or comments, I'm going to direct you guys towards Blackboard. If there are questions, please interject and let me know if there's something you don't understand or something that you'd like me to go over. But otherwise, this is our course shell, and this is our homepage. What we're going to go to is we're going to go down to Module 2. Module 2, again, is week 2, which is exactly what we're in. You guys are going to click on the writing assignment, and this time you're actually going to be writing a paper. So the due date is here, the 17th, which is this Sunday before 11:59 p.m. You're going to go all the way down and you're going to view your assessment, and you are going to read the prompt. And what the prompt says is that you're going to identify a person you know who has an immune system disorder or cancer, okay? The caveat to this is they can have either or. It doesn't have to be just a single one. You can review content in your textbook, so that's going to be directed towards Chapter 2, and choose any of the disorders that are within that chapter. You're going to interview the affected person, and you're going to write a 3 to 5 page paper identifying the following issues. When I say, or when we say 3 to 5 pages, that is excluding your cover page, and it's excluding your reference page. So be mindful of that. In general, you'll have 3 to 5 pages to explain and answer the question appropriately. Remember last week what we did is we went through the APA setup for a paper. It should have everything inclusive of an introduction, your text body, as well as a conclusion. Okay, so whenever they say write a paper, it's going to be in this format. What you're going to do is you're going to identify the pathophysiology of the immune disorder, the treatments, and then you're going to summarize your findings from an interview. So what you're going to be doing is you're going to be interviewing the person that you've chosen that has this given disorder. And if you scroll past this little blurb, you're going to see the questions that you're going to ask your patient or your client. And there are 9 questions. You're going to ask them how they would describe the immune disorder, how long they've had it, how has it changed their life at home and work, are they able to carry out their activities of daily living independently, what treatments are they using to manage this disorder, what side effects have they experienced, how has this disorder changed your body, and how has the disorder impacted the individual emotionally, and then also what alternative therapies such as Eastern medicine like acupuncture, herbal treatment, yoga, what have they tried to alleviate whatever their symptoms are. And this is just a reiteration of question 9. I'm not sure why that's there, but if you go to this little drop-down menu, it has these 3 ellipses. All you have to do is click on it, and it gives you a summary of this page so you can have it. Remember, whenever you're turning in your assignments, it's going to be a brand new Word document. You can use the APA 7 template that's in APA. It's at guides.rasmussen.edu/APA. That's the website, and I'll put that in the Dropbox in a few seconds, or the chat box rather. If you go back up to the main body of your prompt, you are going to use at least one single scholarly source. That can be from academic journals, CINAHLs, textbook references, or any .edu or .gov site. So things like Medline, I think, are .edu or .gov, so those are okay for you to use. UpToDate is also another thing you can use. If you do not have anybody in your family or that you know of that you can interview personally, that has an immune system disorder or cancer, you can actually make this interview up. So you'll use the nine questions to guide your response. You're going to write it up, and then you're going to summarize it. So remember, you're not including all of this dialogue into your paper. What you're going to be doing is you're going to be summarizing it, okay? Are there any questions or comments on this assignment? Everybody okay so far with this? Okay, all right, perfect. And And that's it, basically. The only other thing that you have to do is you have to cite it in the proper format. Remember, you're going to use Microsoft Word, or you're going to use, actually, either Microsoft Word or it should be a PDF. Don't give me a link. Don't give me a Google Doc. Do not give me anything to like don't give me a link, basically. It has to be an actual paper uploaded or an actual file, a Word doc or a PDF. You're going to save it with your first initial and your last name, followed by an underscore and the name of the assignment, and an underscore and the date, okay, just like the example gives you. All right, ladies and gentlemen, so that takes care of our housekeeping for this week. Remember to pay attention to your Blackboard, and you're going to have follow-up for your assignment that you turned in on Sunday. You also have these other activities that are within this module that can help to support or further your knowledge on these topics in case you are curious or in case you want to just have things explained a little bit more. All right, without further ado, what we're going to do is we're going to go into Kahoot and we're going to continue with our review. So this is going to take a little bit of time. Maybe our breaks are going to be a little short for today, but nevertheless, please participate if you can. Participation actually does help you a great deal. A lot of this course is you get what you put into it, and yeah, you guys, you know, I would assume that you'd want to have the best outcome, so I will help you to do that, okay? So I'm going to post this in 2 seconds. This is going to be a review of chapters 1 and 6, so please be mindful of that. You can go, you should be able to see it. Give me 1 second. And you should be able to hear like all the background audio as well. So there you go. Okay, perfect. So your PIN is 9123858, and what you're going to do is you're going to go to www.kahoot.it, which is right here, or you can scan your QR code and just log in. You don't have to put your name. You can just put a fake name. In addition to that, what you guys are going to do is on your cell phone, you're going to see a color that coordinates with the answer choices, and you're going to click that object with the corresponding color, okay? Okay, I'm going to give you guys about 1 more minute, and then we'll go from there, okay? We'll get started. All right, ladies and gentlemen, if everybody has joined, let's get started, okay? Okay, I'll give you like 1 more minute. Here's your QR code, and we'll turn down the music in like a second. All right, ladies and gentlemen, let's get started. Okay. It's going to slow us down a little bit. All right. Okay, let's get started. All right, so welcome to our review, chapters 1 and 6. This is from week 1, okay? So we have like roughly 48 questions or something like that. Solvent movement across to the cell membrane from low solute concentration to high solute concentration is defined by which of the following? Is it osmosis, meiosis, mitosis, or diffusion? Great job, ladies and gentlemen. Osmosis is the correct answer. Great job. You're doing awesome. Question number 2. Blank solutions have a lower concentration of solutes than those in the intravascular space. Is it hypotonic, hyper, combotonic, or isotonic? Great job, ladies and gentlemen. The correct answer is hypotonic solutions. That's correct. Great job. You're doing lovely. Number 3, cells become specialized in their structure and function via which of the following? Is it proliferation, phagocytosis, differentiation, or pinocytosis? Great job. Differentiation is the correct answer. Great job. You're doing awesome. Number 4, which form of cellular adaptation occurs because of decreased work demand on the cell? Is it hyperplasia, metaplasia, dysplasia, or atrophy? Great job. Atrophy is the correct answer. Great job, ladies and gentlemen. You're doing lovely. Number 5, cations are blank charged. Are they negatively charged, positively charged, neutrally charged, or are they ambiguously charged? Positively charged is the correct answer. Great job, ladies and gentlemen. Awesome. Number 6, which disorders are passed from an infected parent to an offspring regardless of sex or gender? Is it sex-linked disorders, Fragile X, autosomal dominant, or all of the above? Remember to pay attention to the concepts in this Kahoot that correlate with your study guide, and you should have all gotten the study guide, okay? Great job. Autosomal dominant is the correct answer. Great job, ladies and gentlemen. You're doing lovely. Number 7, genetic material of a cell is housed in what? Is it the lipid bilayer, nucleus, cytoplasm, or aqueous humor? Great job. The nucleus is the correct answer. Great job, ladies and gentlemen. You're doing lovely. Number 8, the disease state of a neoplasm is called what? Is it the natural killer cells, cancer, aphids, or Lyme disease? Cancer is the correct answer. Great job, ladies and gentlemen. Great job. You're doing fabulous. Number 9, the following defines homeostasis. Is it the state of equilibrium outside of the organism to maintain usual function? It disrupts usual function, it maintains it, or it D. Great job. All right, C is the correct answer without me rambling through it. So great job. You're doing awesome. So all of these are hints for you, okay? So hint, hint. Number 10, fluid found between the cell is called what? Is it called intravascular, interstitial, or intracellular, or all of the above? Great job. B is the correct answer. Interstitial is correct. Great job. Number 11, what is the function of the mitochondria in a eukaryotic cell? Is it to produce inorganic phosphate for energy, produce ATP, produce ADP, or produce inositol for energy? Great job. To produce ATP for energy is the correct answer. Great job, ladies and gentlemen. So number 12 is, we have this many chromosomes. Do we have 52, 23, 46, or 96 in the human body? Great job. 46 total is correct. 23 from mom, 23 from dad. Great job, ladies and gentlemen. All right, you're doing awesome. 13, selective permeability allows free passage of blank in and out of the cell. Is it glucose, electrolytes, enzymes, or all of the above? Great job. All of the above is the correct answer. Great job, ladies and gentlemen. You're doing fabulous. All right. Number 14. This term means an increased number of cells in an organ or tissue. Is it hyperplasia, synaplasia, metaplasia, or dysplasia? A is the correct answer. Great job, ladies and gentlemen. Great job. Number 15, hyponatremia is due to low sodium levels in what? Is it in the cell, the bile, the serum, or the mucus? Great job. The serum is the correct answer. Great job. You're doing lovely. Number 16, blank controls serum osmolality and water balance. Is it potassium, magnesium, chloride, or sodium? Sodium is the correct answer. Great job, ladies and gentlemen. You're doing fabulous. Number 17, this exemplifies homeostatic control. Is it diarrhea, vomiting, diaphoresis, or fever? Fever is the correct answer. Great job, ladies and gentlemen. Great job. You're doing awesome. Number 18, we're almost there. Endoplasmic reticulum does which of the following? Does it house ATP and aid in ribosome production, aids in ATP production, none, or aids in, it houses ribosomes and aids in protein production? Great job, ladies and gentlemen. D is the correct answer. Great job. All right, lovely. Number 19, This type of cell adaptation takes place when a muscle cell is placed in a cast for a long period of time. Is it hypertrophy, metaplasia, dysplasia, or hyperplasia? Okay, so this one is a little tricky, so be mindful whenever you see this in your exam, you will have a very clear answer to this. So hypertrophy is the correct answer. It leaves it a little bit, it leaves it ambiguous a little bit, so be mindful of this question, okay? Great job. And if there is any problem with it, we will, we'll see what we can do about it. Number 20. Which of the following causes edema? Is it decreased osmotic pressure, decreased capillary hydrostatic pressure, increased capillary hydrostatic pressure, or increased osmotic pressure? Great job. C is the correct answer. Great job, ladies and gentlemen. All right, to number 21. One cause of cell death is what? Is it apoptosis, ischemia, necrosis, or all of the above? Great job. All of the above is the correct answer. Great job, ladies and gentlemen. We're doing awesome. Number 22, blank defines a serum potassium level greater than 5 milliequivalents per liter. Is it hypercalcemia, hypocalcemia, hypercalcemia, or hypocalcemia, or kalemia, sorry. Some of them are kalemia, and be mindful of the spelling too. Okay, so hypercalcemia, and it's actually, it should be calcemia with a K, or kalemia with a K, actually. So great job. All right, and that will be clarified. Number 23, muscle tetany, a positive Chebyshev sign, and positive Trousseau results from what? Is it low calcium, high calcium, low vitamin D, or high vitamin D? And we'll go over this as we finish out our lecture from last week. Great job. A is the correct answer. Great job, ladies and gentlemen. All right, we're almost there. 24. Variations of genes are called what? Is it DNP, alleles, karyotypes, or autosomes? B is the correct answer. Great job. You're doing lovely. 25. A form of cell division that occurs only in mature sperm and ova, or aka gametes, is called what? Prophase, oncogenes, mitosis, or meiosis? Great job. Meiosis is the correct answer. Great job, ladies and gentlemen. Great job. 26. This is a symptom of dehydration. Is it vomiting, defecation, diuresis, or thirst? Great job. Thirst is the correct answer. Great job, ladies and gentlemen. 27, the majority of the body's phosphorus is located in what? Is it the teeth, bone, bloodstream, or muscle? Bone is the correct answer. Great job, ladies and gentlemen. You're doing fabulous. Number 28, the likelihood of surviving cancer is the blank. Is it called the disorder, prognosis, remission, or disease? Great job. Prognosis is the correct answer. Great job, ladies and gentlemen. You're doing fabulous. 29, the movement of water between the interstitial and intracellular compartment is called what? Diffusion, osmosis, active transport, or capillary refill? Osmosis is the correct answer. Great job, ladies and gentlemen. You're doing lovely. 30. Number 30, Trousseau and Chebyshev signs are associated with what in the body? Is it high calcium levels, zero calcium, low calcium, or excessive calcium? Low calcium is the correct answer. Great job, ladies and gentlemen. Number 31, fluid excess is exemplified by which of the following? Is it thready pulses and crackles in the lungs, bounding pulses and bronchi, bounding pulses and crackles, or atelectasis? Great job. Bounding pulses and crackles in the lungs. Hint, hint, okay? This is important. Great job. You're doing awesome. 32. When cells increase in size, it is called what? Is it called metaplasia, hyperplasia, dysplasia, or necrosis? Hyperplasia is the correct answer. Great job, ladies and gentlemen. Great job. You're doing lovely. 33. Extracellular fluid contains high concentrations of what? Is it sodium and phosphate, sodium and chloride, potassium and chloride, or magnesium and chloride? We're almost done. Great job. Sodium and chloride is the correct answer. Great job, ladies and gentlemen. You're doing lovely. Number 34, blank is the osmotic pressure of two solutions separated by a semi-permeable membrane. Is it tonicity, pH, ion gap, or pH again? Great job, ladies and gentlemen. Tonicity is the correct answer. Great job. You're doing fabulous. 35, almost there. Acid-base balance takes place in which of the following? Is it body fluids, lungs, kidneys, or all of the above? All of the above is the correct answer. Great job, ladies and gentlemen. You're doing awesome. 36, intracellular fluid contains higher levels of a what? Is it potassium, magnesium, chloride, or phosphate? Great job. Potassium is the correct answer. Great job, ladies and gentlemen. 37, edema is associated with what? Is it hypovolemia, hypervolemia, fluid deficit, or fluid loss? Hypervolemia is the correct answer. Great job, ladies and gentlemen. Great job. 38. A clinical manifestation of fluid deficit is what? Bounding pulses, hypotension, hypertension, or rapid weight gain? Fluid deficit. Great job. Hypotension is the correct answer. Great job, ladies and gentlemen. You're doing fabulous. 39. Eradicating the disease is the goal of what treatment? Is it curative, prophylactic, palliative, or all cancer treatment? Great job. Curative is the correct answer. Great job. You're doing fabulous. Number 40. Bones are reservoirs of what? And is it magnesium, potassium, phosphate, or calcium? Great job. Calcium is the correct answer. Great job, ladies and gentlemen. You're doing awesome. 41. Most of the body's calcium is found in these two locations. Is it the bones and teeth, the gums, dentures, muscle, tendon, or ligament and cells? Teeth and bone is the correct answer. Great job. You're doing fabulous. 42. The most significant cation is what? Is it potassium, magnesium, sodium, or calcium? That's in the human body. Great job. Sodium is the correct answer. Great job, ladies and gentlemen. You're doing awesome. 43, we're almost done. Solute movement from an area of high concentration to low concentration against the gradient with ATP is what? Osmosis, facilitated, active, or diffusion? Great job. Active transport is the correct answer. Great job, ladies and gentlemen. 44. The main intracellular cation is called what? Calcium, sodium, potassium, or phosphorus? Potassium is the correct answer. Great job. You're doing fabulous. 45. We're almost done. Metabolic alkalosis results from these two things. Is it high bicarb, low pH, both A and B, or neither? Great job. Neither is the correct answer, okay? So be mindful and then just look into what those actual parameters are. 46, an IV fluid that forces fluid to move from an extracellular space to intracellular space in a blank solution is what? Is it isotonic, hypertonic, hypo, or none of the above? Hypertonic is the correct answer, so great job. That is awesome. You're doing lovely. 47. This results from low bicarb or excessive hydrogen or acid. Is it metabolic alkalosis, respiratory acidosis, metabolic acidosis, or respiratory alkalosis? Metabolic acidosis is the correct answer. Great job, ladies and gentlemen. You're doing lovely. Last but not least, an imbalance in this ion causes an imbalance in acid and base. Is it hydroxide, calcium, potassium, or hydrogen? Great job. Hydrogen is the correct answer. Great job, ladies and gentlemen. You did a lovely, fabulous job. So thank you very much for your participation. All right, we are at 9:55. We're actually going to take a small, tiny break. Remember, these things are actually hints for you, so be mindful of it. Congratulations. You all did amazing. We're going to come back at 10 a.m. on the dot, and we're going to get started with our lecture, okay? If there are any questions, please let me know, and we'll go from there. So happy break number one. Please come back at 10 a.m. and we'll get started again with our finishing our last lecture. No. All right, ladies and gentlemen, welcome back. I hope you're still with me. And I know that if you guys have any questions, actually, please just let me know. It will be in everyone's best interest just to elucidate some concepts if we need it. If there are no questions, we're going to get started with our lecture. What we're going to be going back.
Question.
Oh, yes, ma'am, please.
Hi, sorry. I wanted to know with the Kahoot questions, could we possibly get those as part of our study guide, or will we not have access to those?
You will have access through a recording. So what has been happening is I've been having a dissemination problem through Kahoot. And even though I put everyone's email, people don't get them. Either it goes somewhere else or they say that they don't receive it. So I eliminate all the problem and just have it in the recording. You guys can go over them in the recording. I know that doesn't give you a chance to play it, but you should be here to play it in class anyways. So that way there's no ambiguity and there's no IT issues. So yes, you will see this again. Today, I will send it back to you and make sure that you have the recording at your disposal. So it goes in tandem with your study guide. Okay.
Okay, thank you so much.
No worries. All righty, so everybody should be able to see the PowerPoint in front of you. We're going to go through it. We're going to conclude it, rather, I should say. And if you have any questions, please interject. Again, when I have this PowerPoint in front of me, I cannot see your beautiful faces, but just to verbalize it, and I'll try and answer it to the best of my knowledge. So as we saw, sodium is a very vital electrolyte in our human body. We have clinical manifestations like increased temperature, warm, flushed skin, dry, sticky mucous membranes. For the hyper and then hypo is our clinical manifestations are a little bit different, but they kind of mimic each other in different ways. When you lump all of these electrolytes together, it kind of blends together. So to elucidate that and make it clearer so you guys aren't like memorizing a whole 16 pages per electrolyte, refer to your study guide and make sure that it makes sense to you and that you're zoning in on the ones that are very critical. We have, for the hyponatremia, we have edema, we have headache, we have lethargy, we have muscle weakness, seizure, and coma, etc. So your textbook gives you a great rundown on that. Moving forward, chloride is something that is a mineral. It's a mineral electrolyte, which is primarily in the extracellular space, so hint for that. We talked about chloride is usually in tandem with sodium chloride, right? So you have a salt molecule that enters into water or into the bloodstream, it dissolves, and then it dissociates into sodium as well as chloride. Specifically, we have abundance in our gastric secretions, like our pancreatic juices and our bile. As well, there is a lot in our cerebrospinal fluid. We need to have functioning kidneys to process chloride, so sweat whenever we also sweat. So to cool our body excretes chloride to help that cooling process as well. Recommended daily allowance for consumption is 3 to 9 grams. In excess, we have a hyperchloremia state where we have excess chloride that is greater than 108 milliequivalents per liter, and that results in its own clinical manifestations. However, similar to the majority of these excessive and deficited situations, a lot of this is difficult to see because clinically your patients aren't going to really present with something that's very iconic to this, like some of the disorders we're going to see later on. But for the most part, we have an issue, and these issues can arise once we check the blood. So your patient is going to complain of something like very general, like fatigue or pain, or they might have, decreased sweat excretion or something that is iconic to chloride. In the hypochloremia section, this is where our serum level drops below 98 milliequivalents per liter. And again, there's no specific clinical manifestations that are directly associated with hypochloremia. Your textbook mentions a few things that are associated with a generalized symptoms that will present, but it's not really iconic, and this is presented in this slide here. Moving forward, potassium is something you guys are going to have to deal with a lot in not only this class, but you're going to see this recurrently and drilled into you a lot through ATIs whenever you get to it. The ranges for all of these electrolytes are going to be variable because this is for your textbook. So also be mindful of that whenever we ask for levels or ranges of certain, certain lab value. These lab values are going to come from your textbook for this course. And then when you guys get into ATI and the rest of the stuff, it's going to come from a NCLEX source. So just keep that in mind. Potassium is your primary cation. It's intracellular. It's mainly in abundance intracellularly. It is responsible for a lot of things, and it can also drive you into cardiac arrest if you have it in excess. So mainly we see potassium play a key role in electrical conduction within the nervous system as well as within the cardiac system. It plays a role in regulating the acid and bases, and it also plays a role in metabolism. Things like sugar, protein, and carb processing, as well as fats, is where potassium is directed towards. What happens is we have, your textbook makes note of this, so hint for this. This is a concept that was reiterated in the Kahoot. Potassium sits in the intracellular space in a reserve format. So whenever it's needed, it is pulled from that location. So that correlates with your Kahoot for a reason, so hint for that. Whenever we need to excrete it, just like chloride, we need to have functioning kidneys to excrete potassium as it is lost through the GI. So pooping and peeing is kind of where it is excreted. In terms of recommended daily allowance, we have 40 to 60 milliequivalents, and the normal range for potassium, hint, is 3.5 to 5.3 milliequivalents per liter per your textbook. In a hyperkalemic state, this is when our potassium levels are greater than 5 milliequivalents, and it's very unusual for healthy people to experience this. However, when they do, or if somebody does experience levels that are very, very high, it is deemed a medical emergency. This is where we have a lot of cardiac arrhythmias and dysrhythmias that take place. The heart rate speeds up and it beats kind of extremely erratically, and without any intervention to drop that potassium or sequester it from the bloodstream, the patient can go into a stroke and then pass away. In a hypokalemic situation where we have a low level of potassium, less than 3.5 milliequivalents, this can also happen too. Your patient can be driven into cardiac arrest. Similarly, they'll have cardiac dysrhythmias, and then they'll degrade, or sorry, not degrade, but they will decline in their cardiac stability if it's not corrected. So this can happen for a lot of reasons. Whenever you have excessive loss of potassium, or you don't take enough, or you have increased cellular uptake for whatever reason, you can have a hypokalemic state. By definition, or in your textbook, you have your patient will have muscle weakness. They might have paresthesias, which is numbness and tingling in their hands and their feet. They'll have changes on their EKG, which we're going to talk about in 2 seconds. And they might have constipation or confusion, or they might have cardiac arrest. That's in a hypokalemic state. These are the clinical manifestations. On a hyperkalemic platform, we have anxiety, we have bradycardia, we have respiratory depression, abdominal cramping, nausea, diarrhea, to rid the body of the potassium. And then again, you can see the overlay. Your patient might have muscle cramps, and they also have muscle weakness, and they will also have, if excessive and not corrected, they will have cardiac arrest, or they'll go into cardiac arrest. Why is this important? So whenever we look at the patterns for our heart, we're going to talk about this when we get into our cardiac chapter. We have what's called an EKG, and an EKG is what measures the conductivity in the parts of our heart, all throughout our heart, from the top atria to the bottom ventricles. And in general, we have our normal tracings. What an EKG does is it captures those electrical activities, and it measures them against 3 primary waves. We have a P wave, a QRST complex, or a QRST wave, and then a T wave on the end part of the EKG peaks. These are 3 peaks that are very important. It deals with atrial contraction, atrial dilation or relaxation, and then a mix of both in the middle. So whenever we have normal levels of potassium and our levels fall between 3.5 to 5.3 milliequivalents per liter, it kind of looks like this in general. And then depressed ST segments or T-wave inversion happens whenever we have erratic levels, whether our levels are super, super low or super, super high. So our EKG is actually going to look distorted, and that's bad because that tells us that whatever part of our heart is being examined, it is actually malfunctioning and being erratic, or it is being it's under functioning for whatever reason. And it's most of the time, or sometimes, it can be associated with, potassium levels, which is very insane to think that such a minute thing is, would cause such a great deficit. Moving forward, calcium is found in our bones and our teeth, hint, hint, and the rest is mainly found in its ionized or unbound state, which can be used, which can be viewed for physiological processes, usually functioning in blood clotting and within our circulatory system. The most important thing about calcium is not only that it's found in bones and teeth, but it also has an inverse relationship with phosphorus and magnesium. So to remember these relationships, you'll think that calcium is inverse to phosphorus, but parallel to magnesium. So for example, when you have calcium levels are high, usually your magnesium levels will be high as well, or magnesium is required for it to, in a decent level, for calcium to be absorbed. And then for phosphorus, it has an inverse relationship. So whenever calcium is high, phosphorus is usually low, and vice versa. As your textbook states, calcium requires magnesium to fully function and to be in proper balance. And in addition to that, vitamin D helps to absorb calcium. So whenever you take your over-the-counter pills or your vitamins, you kind of see that usually calcium is always paired with vitamin D for that absorptive property. It helps ingestion and absorption in the GI tract. What else? So recommended daily allowance is allocated at 800 to 1200 milligrams per day. And usually calcium is excreted largely when it's in excess in the urine. Hypercalcemia occurs when ionized calcium levels climb higher or when it's greater than 5 milliequivalents per liter. And this is due to excess calcium intake or, excess calcium release from the bone or well from inadequate excretion. Hypocalcemia occurs when ionized calcium levels drop below 4 milliequivalents per liter, and this is usually due to increased loss of decreased calcium intake. Moving forward, we have the hyper and hypocalcemia levels. So again, we have for both of these things, we have clinically our patients are going to have confusion. They'll have headaches. They might have lethargy. Remember we talked about in our review, the positive Trousseau and Chebyshev signs. So hypocalcemia is whenever you have a low levels of calcium. If you hit right above, or it's ideally right in front of your ear, or if you see muscle twitching, which is called tetany. This indicates low calcium levels. And what happens is if you stroke around your cheek area, you'll see that your muscle or your cheek will twitch a little bit, and that will give an indication that you have low calcium levels. Okay, so that was a hint as well. Phosphorus is mainly found in bones with smaller amounts circulating in blood. This again is required through entry via the diet, and it is wasted in the urine. RDA is approximately 1,000 milligrams per day. Phosphorus absorption of phosphorus usually is decreased when it is consumed with foods with calcium, magnesium, and aluminum. So all of these things kind of bind phosphorus and it sequesters it. So this is problematic. We want to avoid consumption. However, our body kind of usually makes up for it depending on what it is. Hyperphosphatemia occurs when phosphorus levels climb above 4.5 milligrams per deciliter, and it results from decreased excretion of or increased intake of phosphorus. Hypophosphatemia is when you have phosphorus levels that are lower than 2.5 milligrams per deciliter, and this is usually due to increased excretion or decreased intake of phosphorus. Similarly, we have our high and low levels. Clinically, what we're going to see in a high level or even in a low level is where your patient has, they might have renal failure, or if they have hyperparathyroidism. Some of this is what our patients will have, what they will exhibit, or what the causative agents will be. Alcoholism is something that can also cause a deficit. So malabsorption, low vitamin D, or taking magnesium and antacids will kind of sequester phosphate as well. Clinically, we're going to see our patients have similar clinical manifestations that are associated with hypercalcemia. Okay, magnesium. An intracellular cation is, which is again mainly stored in our bone and our muscle. Again, magnesium is super important. It's another one of those electrolytes that kind of control everything. It functions in our nerve system, our cardiac system, our immune system, bone health, sugar level regulation, blood pressure even, as well as protein synthesis. And it, again, as we talked about, has a direct relationship with calcium and an inverse relationship with phosphorus. RDA for magnesium is about 400 milliequivalents per day. And then again, we have our high levels of magnesium and our low levels of magnesium. Hypermagnesia is when you have a magnesium level higher than 2.5 milliequivalents. Usually rare, but it is possible for patients who have renal failure. or if they use a lot of antacids regularly. Hypomagnesia is when you have magnesia levels that drop below 1.8 milliequivalents. And that is a result of sequestration. So things like alcohol consumption or malnutrition, or people who are pregnant or who have preeclampsia, or even if they take a lot of diuretics or they have diarrhea or they're super stressed out, this is when their magnesium levels can drop. So again, this is kind of reiterated in this little blurb at the bottom for hypo, and then hypermagnesia is also at the top as well. And it directs you towards treatment. So your book elucidates that, but always compare that to your study guide and make sure that it correlates so you're not, overly abundantly remembering everything. Acids and bases is another topic that is going to come on exam 1. This topic is going to be reiterated through your entire course of things. Or not only in this class, but in classes that are going to come after this, as well as NCLEX. So very important to note. A lot of students have been exposed to this, whether it's in basic chemistry or not, but acid and base is by definition the measure of hydrogen. And we have a number scale here that ranges from 0 to 14, where 7 in the middle is neutral. And then we also have basic basicity, where we have higher levels of OH ions, and then acidity, where we have higher levels of hydrogen ions. So basically, as our little statement says, the higher the hydrogen concentration, meaning that our number scale shifts towards the lower end, the lower our pH number is going to be, and that's going to be around this end or this range of the pH scale. And you can also see some of the great examples that that your textbook provides of what these extremely acidic versus neutral versus basic solutions look like. Whenever we have acids and bases, our body needs to have a buffer that aids in the excessive acidity or excessive basicity modulation or fluctuation in general. Our body needs to be neutral in order for everything to function correctly. So there are 4 major buffer mechanisms in our body: bicarb, carbonic acid system, phosphate system, hemoglobin, and the protein system as well. The acid-base balance process is broken down into 2 main forms. So we have the respiratory as well as the renal regulation or kidney regulation. By definition, your respiratory acid-base balance changes by changing the way carbon dioxide is excreted. So in your mind, you should always think of carbon dioxide or CO2 as the acid in our body. In our respiratory regulation, we speed up our respiration, and by speeding it up, we're blowing off more CO2. And by blowing off that CO2, we're taking out the acid from our body, and we're decreasing the acidity within our own body. For example, when we have our patients that are very slow and shallow in breathing, or they have bradycypnea, they are actually having a difficulty to breathe normally. So they actually decrease their breathing. That means that they're going to hold on to the CO2, and by definition, they're going to become acidotic in the sense that their system will retain that acid and they'll have a surplus of it. In general, your respiratory system reaches its max response in about 12 to 24 hours for the way it's respiring. However, patients can become limited and fatigued during this time, so sometimes it doesn't correct itself. When that happens, we have our renal system to back us up. So our renal system is a slower, more long-term change or fluctuation of pH This can kind of happen over hours to days for its buffering effect to happen, but it's most long-term. It's mainly the most long-acting action. So here, the kidneys are going to exchange, or they're either going to excrete or retain hydrogen, which is an acid, or they're going to excrete or retain bicarb. Bicarbonate is defined by HCO3 with a minus sign at the top. This is a base, and this basifies our system in general. So the renal system functions to permanently remove hydrogen from the body to decrease the acid in theory, and it fluctuates bicarb as needed. Whenever we're in a compensatory state, this is when our body is trying to make up for whatever deficit it has. And this is enabled, or this is geared towards homeostasis or maintenance of homeostasis. And this is how our body changes. It never overcompensates, and it is enacted with its main objective to balance its pH altogether. So if the pH is more acidic because the lungs have decreased output, or our patient can't breathe properly, the kidney system or renal system will kick in to compensate for this deficit by releasing more carbon and excreting. It's releasing more bicarb, so it's retaining it, but it's actually spitting out hydrogen. And that's going to help to balance the activity of the lungs, which are retaining more CO2. If the patient has a lung disease, which increases carbon dioxide excretion, so for example, your patient is hyperventilating, or they have some other disorder which is causing them to rapidly breathe, they are blowing off CO2 at this point. This is going to increase the pH, which, remember, that's going to shift the pH scale towards the left. The kidneys are then going to compensate by slowing down the production of bicarb and hydrogen excretion. So it's going to kind of compensate for the excessive CO2 being blown off, which is the acid. So now it's going to retain the hydrogen to make it more acidic, and then decrease the production of bicarb, which will compensate for the alkalinity of the system. Your textbook kind of goes over this in a nice little chart. It breaks it down into the the respiratory as well as the metabolic aspect of these two things. You have acidosis and alkalosis on either side, and this is what your diagnostic findings are going to look like for each of these scenarios. However, the best way to memorize this is through this chart. So we're talking about what are called ABGs, and these are called arterial blood gases. In your wrist, you're going to see you have arterial blood, and that's located in your wrist and in your lower hand. Here we can measure things like pH, O2, CO2, and bicarbonate, as well as our oxygen levels. We also have normal ranges for this. So what you have to do is you have to actually remember these normal ranges. Remember, the normal ranges that we find are based on what your textbook is going to provide. And this is going to be based on the pH, which is usually 7.35 to 7.45. O2, which is 95 to 100, CO2, which is 35 to 45, and then bicarb, which is 22 to 26 milliequivalents per liter. Excessive base, and then arterial O2 saturation is not really important. Our oxygen saturation should always be closer to 100. Otherwise, your patient is going to have a bunch of symptoms like headache, malaise, weakness, fever, coma, anorexia, etc., and dysrhythmias. We are going to go through the 4 scenarios of what this looks like. So metabolic alkalosis is our first scenario. This is where we have excess bicarb or a deficit of acid or both. This causes our pH to be greater than 7.45, okay? So to treat this, when we have our patient that comes in with this scenario, we need to stabilize our patient. We have to address their hydration, their electrolyte imbalance, and address whatever the cause is. So a few causes can be like our patient takes too much antacids, or they have too much bicarb, or they have low chloride levels, sorry. They might also have other things going on, like they might have an NG tube or a nasogastric tube that's suctioning up their gastric contents. They might have renal failure or hypovolemia. So for whatever reason, we have to fix this scenario. Respiratory acidosis is where we have carbon dioxide retention. So your patient becomes acidotic as a result of too much carbon dioxide in their lungs, which drops their pH back to the acidosis or the left side of the scale. And when our patient is usually breathing less, or like, let's say if they have emphysema, or if they have asthma, excessive asthma, or if they have COPD, any of those that cause our patient to breathe shallowly or have decreased respirations is going to thwart the way their gas exchange happens. And this is the scenario that's going to help them or cause them to hold on to their CO2, and that's going to make them acidotic as a result because they have now too much acid. Treatment for this is going to be to relieve the low oxygen levels. So by nature, we know that CO2, when it's increased, our patient, hold on. There you go. Our patient is not going to have too many, they're not going to have sorry, we had background noise. Okay, so at this point, what we're going to see is we're going to see our patient have low oxygen levels because they have too much CO2, and that when they have too much CO2, it's called hypercapnia. And to fix this, we're going to put them on oxygen. We can put them on a mechanical vent. We can put them in a high Fowler's position, so that means completely straight up at 90 degrees. We can do a bronchial hygiene, meaning that you basically wash and rid their body of bronchial secretions. And then we can also treat them for antibiotics treat them with antibiotics for something like pneumonia if they have, or if they whatever the underlying cause is. Respiratory alkalosis is something else that your patient can also have. This happens as a result of excessively blowing off CO2, and this can lead to carbonic acid deficit, so CO3 deficit, as well as an increased pH. This usually occurs again as a result of hypervolemia. Here, this causes an increased CO2 level, which is very critical for our patient. And, you know, basically whenever our patient's hyperventilating, we want them to breathe into a paper bag and have them rebreathe that CO2. So what are they going to experience? They're going to experience syncope. They might have muscle tetany. They might have dry mouth. They might have tachycardia, and eventually they might fall into coma if it's not resolved. Mixed disorders. For mixed disorders, you can have a mixture of both acidotic and alkalotic outcomes in the respiratory and renal system as well. And here's where your book runs everything down, and this is what your ABGs kind of look like. So in steps of how to solve these problems, you're going to look at the pH, and this kind of measures the concentration of hydrogen in the plasma. Then you're going to look at the CO2 or partial pressure CO2. PaCO2 is just usually abbreviated as CO2. This indicates pulmonary ventilation. HCO3, which is your bicarb or bicarbonate. looks at the way your kidneys are functioning and retaining or excreting excessive bicarb. And then PaO2 is your partial pressure of oxygen, which gives an indication of your oxygen in the blood. We also have our ABGs as well, which focuses on our pH, CO2, and bicarb. And then just as a tidbit, we always want to recall that that our CO2 is our acid, CO3 is our base, and then if you have more acid, it's going to drop your pH, where less acid will raise the pH. If you have more base, it raises the pH, and then where you have less base, it lowers the pH, okay? I know that's kind of confusing, but it super makes sense on the pH scale. This gives you an overview of how to walk through it in a general of how to solve these problems. But in my opinion, when we go through chapter 2, you're going to have a very clear version of how this is broken down. There's also a video that makes this system really easy. When you want to quickly remember this, memorizing this chart will help you very, very much. So if you're going to be given a parameter for your patient, and they're going to have different levels of their pH, CO2, their oxygen levels, or CO3, and you're going to have to figure out if they're compensating, if they're in respiratory acidosis, alkalosis, acidos, metabolic acidosis, or metabolic alkalosis. And you're going to wager that in general. So your pH, basically, you just follow the parameters. For respiratory acidosis, you have a low pH, high CO2, and your normal bicarb. For respiratory alkalosis, you have a high pH, a low CO2, and a normal bicarb. And then for metabolic acidosis, you have a lower pH and normal bicarb, as well as you have a normal CO2 and then a low bicarb, and then so on and so forth. Your compensatory parameters are here. So this is exactly when you will know that your patient is compensating, and the question should be super straightforward. All right, quick knowledge check. Which of the following does not apply to benign tumor cells? And this is just a small review question. The correct answer is actually C. Liberating enzymes and toxins that destroy tumor and normal tissue. And the second question is, which of the following statement is true, or is it false? The cell membrane is made up only of lipid and cholesterol, and that is actually false because it is made up of proteins as well. So we talked about that, and we talked about its composition. All right, ladies and gentlemen, we are at the conclusion of our first lecture. If you have any questions or comments, please let me know. I hope nothing was confusing. Always refer that back to your study guide. At this point, we are going to take a 5-minute break, and we're going to flip towards Chapter 2. You all should have had your Chapter 2 lecture notes disseminated in your student emails. So you have your lecture notes, and we're going to go through the lecture, and we're going to do a recap video. Our next section is actually quite important. I think it's really interesting. So we'll go forward with it. I'm going to ask that you come back at around 10:42 a.m. and we'll get going with this material as well. Okay, so happy break number 2. We'll see you at 10:42. Perfect. Okay, yeah, and do let me know if you didn't get any of the material as well. Okay, perfect. All right, welcome back, ladies and gentlemen. So what we're going to go over now is we're going to go over Chapter 2. Please let me know if you have your lecture notes available. You should have all, found it. It should be readily available to you. If you don't have it, please let me know and drop your name into the chat box. I hope you all can hear me at this point. We are going to go forward, and let me just set this up a little bit. Okay, so we're going to go forward. Again, when I have this in front of my face, I can't really see. I can't really see your beautiful faces, so please let me know if you have any questions. Just please interject. Chapter 2 is our immunity chapter, very important information. It's very good information as well. Our body, the chapter starts off on stress. Everybody in this universe experiences stress to some degree. It's usually the way we handle it that is the most effective way out in general. By definition, stress is something that a human being experiences, and it can affect our body's way of processing homeostasis, basically. So it will disrupt our normal natural balance in general. And this can happen on any level, whether it's a positive event like a wedding or a vacation. We can still exhibit or, undergo stress. We can also have stress from negative things that are even worse in severity, like diseases or accidents, auto accidents. The concept of stress, or the way our body adapts to it, was developed from this individual called Hans Selye. This is where we have bodily changes that are associated with stress, which took place in the 1930s. Basically, our body responds to a stimuli, which is a stressor, with a series of non-specific events and as a cascade. And this concept was called the general adaptation syndrome. Here we have a cluster of systemic clinical manifestations where our body kind of tries to accommodate or acclimate to cope with the stressor. Factors that can affect the adaptation is mainly natural reserves, time, our genetics can play parts in this, our age, our gender, if we're male or female, or, we don't have a specific gender, our health status, nutrition, the way our body wakes and sleeps, our hardiness, so how tough we are to a certain thing, or our psychosocial, physical mindset. General adaptation syndrome is where we have 3 stages, so hint into this. We have the alarm phase, we have the resistance phase, and the exhaustion phase on 3 parts. So in the alarm phase, this is where our central nervous system, adapts, and it releases 2 main, we could call them proteins, or we can call them enzymes, catecholamine and cortisol. This helps in what's called our fight or flight. So basically in this stage, our body decides to either handle a situation where it fights for, positive outcome, or it flights. Maybe it cannot handle this and it just shuts down completely. This is where our patients exhibit syncope, or they literally have to exit a certain scenario because it's overwhelming for them. In the resistance stage, our body chooses the most effective way and advantageous way to handle a certain situation. So here, after our catecholamine levels and cortisol level increase because we're super stressed out and our body is going into panic mode, once we're in the resistance phase, our body kind of decides to resist or fight, and the cortisol levels return to its normal level, and then our symptoms of fight or flight kind of disappear and drop. So we have either the adaptation phase or we have an alteration in the mechanism, which becomes our body becomes desensitized to the stressors. We have in this desensitization, we're doing some external intervention that helps our body to relax. So meditation, relaxation, yoga is where we desensitize it. Exhaustion. Our body goes into a phase of exhaustion when it can no longer handle whatever is going on. So it is initiated, in the exhaustion phase, if the stressor is prolonged too much, the body goes into an overwhelming state, and it becomes depleted of everything becomes damaged, and our homeostatic balance is thwarted, and we have no more ability to have our compensatory mechanism. And if this is actually perpetuated and we don't handle it properly, our body can result in extreme disease, and if not corrected, it goes into a death phase. Some diseases that can be exhibited by stress or anxiety, so patients, or even, taking an exam, you go into an extremely anxious state. Depression is another thing. Headaches are another thing. Insomnia, lack of sleeping, having an infection, or having cardiovascular disease are just only a few of the maladaptations that happen when our resources are depleted in general. So this schematic kind of shows you what our general adaptation syndrome looks like on a systematic level. So all 14 systems within our body, we can have a bunch of things that go awry whenever we have too much being imparted in a given system. Something as simple as eczema, you can think of an adaptation syndrome, because our body is actually reacting to that fluctuation in our hormones, and our hormones are not properly placed, so they become extremely erratic. Hair loss, alopecia, all of these things, even psoriasis, are just localized to that one system. So on the left side of this slide, you have a graphical representation of what this looks like during the alarm stage, the resistance, and then the exhaustion stage as well. Your body uses its resources to acclimate to an environment. It kind of plateaus, and then it goes into exhaustion with a depletion of its reservoir if it cannot handle things properly. Just like we have our general adaptation syndrome, we too also have what's called a localized adaptation syndrome, or GAS. It's a GAS and an LAS, which is the abbreviated version, but we'll just stick to calling it the localized adaptation syndrome. Here, this is the same thing on a localized basis, or a local area basis. So the stressor in this case is confined to a single location, and the most common system that exemplifies this is the local inflammatory response. So for example, in our body, whenever we have an injury or we have damage to our cellular network, which is caused by multiple things, like chemical agents, pathogens, or even microorganisms like bacteria or viruses, our body in that given area, or even an injury like a laceration, our body undergoes a localized adaptation syndrome, or sequence of steps that kind of help to compensate for whatever deficit is being imparted in that given area. So for example, our capillaries start to widen. This increases with blood flow. That increase of blood flow causes heat or warmth to that area, so hint for that. Then you have increased permeability with fluid release into the tissues. That causes redness. Then we have an attraction of what are called leukocytes to that area. So your white blood cells are alerted. They are released as a result of the hormones or signals, cellular signals that are released to attract the cells to that given area. And we have what are called extravasation of the leukocytes to the injury sites. That shunting of your white blood cells causes tenderness or softness or like slight discomfort at that area. And then if you have a proliferation of these cells, which, now they're running to the site to help patch or prevent excessive damage, then we have pain in our system. So we have localized pain, and then if that localized pain is not quelled or if it's not minimized, it goes to the entire body, and you have a systemic response as well. So your body can result in fever or, fatigue, which is basically saying that one part of your body is not working properly. Now it's become so bad that your whole entire body is involved as well. All right, quick knowledge check, ladies and gentlemen. Is this statement true or false? Homeostasis is the result of all body systems working together. It happens by chance rather than design. This statement is actually false. Homeostasis is a very tightly controlled process that a healthy body strives to maintain. So even when our body is unhealthy, we're always trying to get back to that healthy state and maintain that homeostasis so everything works in a sequential order. The immune system is responsible for protecting and eliminating organisms. So we are exposed to a bunch of things in our environment, both on an internal and external level: bacteria, fungi, protozoas, parasites, prions, as well as environmental toxins like chemicals and pollutants, and even pesticides and drugs, as well as other foreign bodies. We are exposed to all of this, and our body actually has to fight this off. Even things like cancer cells. So whenever we have cells that are nicked or cut or mutated or they're damaged in some way, sometimes, or even if they form a new, like a neoplasm, as we talked about last class, as a result of, whatever is in the environment that's causing them to mutate in a negative way, or cancer cells, our body on a cellular level is going to go into an attack mode to promote the survival of the fittest mentality on a cellular level. In order to do that, we have a few forms of defense within our skin and within our body. So our innate defense is localized to our skin, our mucous membranes, our phagocytes, our inflammatory response, that all work together in tandem to make sure that the process moves smoothly. Adaptive defense is on a cellular level and also functions on a humoral immunity level, basically within our cells. And then again, we have this great old lymphatic system, which you're going to hear a lot about, where you have the ability to recognize an antigen or foreign substance that is amplified within our body in general. And we're going to talk about that. We have a lot of key terms that are in your textbook. So table 2-1 is very important for you guys to know. Just run this over, like read it, and then look at the cells. These cells come on your test a lot, so hint for that. It's not only the neutrophils, but it kind of goes down in a list, and we're going to see a video that recapitulates that. So important to watch for every viewer. I would think everybody in this class can benefit from that. But if you want something that's in tangible written form, go to table 2-1. It kind of gives you a breakdown of things. So like the antigen is a foreign agent that triggers the production of antibodies by the immune system. Antibody is what is generated as a result to neutralize that virus or bacteria. We have the thymus, we have our lymphatic tissue, we have our bone marrow, and it kind of runs down all of that stuff without going into too much detail. Another thing that's going to be very important for you guys to know, and another hint that is going to come on your exam, is the differentiation between innate and adaptive immunity. So we have innate immunity, which is, by definition, it's called immediate protection. These are our physical barriers to the world. We have either physical, like our skin, we have chemical barriers, and then our cellular defense. On the flip side of that, we have adaptive immunity. which usually takes about 7 to 10 days to provide proper protection, and it is usually antigen specific. So whenever we think of adaptive immunity, you're going to think that it has two pathways. It has active immunity as well as passive immunity. In active immunity, you can have natural immunity, where this is where you get a virus or a cold or some type of thing that you acquire in nature. That is your antigen, and then your body is going to make the antibodies to that antigen to fight off that naturally acquired pathogen. Then you can think of vaccinations. So vaccinations basically have an antigen that is injected into your body, and your body is forced to make antibodies as a result of it, as a result of these foreign particles that are into the bloodstream. And then it, protects against whatever, antigen is imparted through the production of what are called memory cells. Passive immunity is another pathway to adaptive immunity, and we have basically two ways to view this. Maternal immunity, so you have passive immunity. You can view it as an example of mother to baby. So whenever you have antibodies within a mother that's carrying a fetus, once the baby is born, those antibodies are disseminated from the mother to the baby without being imparted in any way. So one very common example, hint, hint, is breastfeeding or breast milk. Mothers transfer immunity to their infants through the passage of breast milk. Antibodies hang out in breast milk all the time. Whatever immunity the mother has is disseminated through breast milk. That is one of the benefits of having a breastfed baby. Another aspect of passive immunity, or example rather, is artificial immunity. In artificial immunity, you have what are called like recombinant antibodies. These things are grown in a lab, and they are actually injected into the bloodstream of the patient. So you have the antibodies at this point that are being directly injected into the bloodstream. To elaborate on this, we'll go by part through innate immunity and adaptive immunity. Innate immunity is the first line of defense, and it is non-specific. We have our skin and our mucous membranes, as we just talked about, and we know that our skin is the largest organ in our body. It is super, super thick. It's very impermeable. It is rich in vascularization, meaning that it has blood. It also has cells, and this is the dermis. And then we also have our mucous membranes, which are also made up of epithelial cells, which are produced in the inner layer of our dermis. And basically these cells, epithelial cells, kind of push their way up in kind of a line. If you think like these cells are layered out, and then they push and then they replenish. So this kind of helps, this continuous shedding process kind of helps the organisms to be pushed off or sloughed off of the surface, so the surface remains intact. There are also multiple examples of this. Our body has other ways to deter pathogens from entering into our fragile homeostatic system. Things like our skin producing hyaluronic acid, which is a slight acidic substance that kind of coats the skin. Then we also have proteins, which are defensins, or it's exemplified by defensins and cathelicidins, kind of a hard word to pronounce. But these cells are just examples of cells that inhibit bacterial growth. Hydrochloric acid within the stomach, we all know that is super acidic, and it kind of destroys or lyses any ingested bacteria within our body. And then tears and saliva have what are called lysozyme. And these enzymes dissolve the bacterial cell walls, and it helps to obliterate the bacteria or the enzymes as well. As we talked about, another thing that's super important, or the same thing, but just more amplified, is the inflammatory response. hint towards that is going to be covered in your exam as well. Our inflammatory response is basically whenever we have a damage to our tissues or trauma, regardless of whatever the cause is, your body exhibits a series of set reactions that take place every single time to make sure that our body is going to regain its homeostatic ability. So acute phase inflammatory response is going to start immediately after the injury, and it kind of continues until the threat is eliminated, which results from hours to days. The steps for this are erythema, which is redness, edema, which is swelling, heat, and then pain at the site of injury. In the chronic phase, we have the chronic phase kind of takes place whenever the acute phase doesn't work. It lasts until the repair or the damage is healing and the repair is complete within weeks to months. So it's going to kind of take place behind the scenes, and it's always going to regenerate. Things like mycobacteria, tuberculosis, or treponema pallidum is kind of something that will be, exhibit so much damage that your body will always continuously mount an inflammatory response. And whenever you have chronic inflammation, your body is going to be pumping out these macrophages and lymphocytes to the site of damage so that way they are healed. We don't have time to watch this video specifically, but I do advise that you do. The inflammatory response is recapped in this video. It's a very good video that summarizes everything. So please watch this at your own leisure, and you have it, it's embedded here. It's 14 minutes, okay? Roughly 14 minutes. So quick knowledge check before we do our own smaller recap video. Which type of immunity is characterized by the development of a specific response to an antigen? And the correct answer is actually acquired immunity. So as we talked about, acquired immunity results from an antigen acquisition, which forces the body to develop humoral and cell-mediated immune response in the fact that they generate antibodies in a form of combating the antigen. Okay? We also have some molecules that help our immune system to actually function. So these three things are kind of important as well. Or these three systems are kind of important as well. They are molecular systems. The first one is called pyrogens. By definition, pyrogens are molecules that cause a systemic inflammatory response, and they are released by what are called macrophages that have been exposed to bacteria. So whenever a macrophage comes in contact with a bacteria or, they are caused by a bacteria, these pyrogens are released, and it signals the body to say, hey, this has happened and we need to initiate the inflammatory response, as we talked about before. The second system molecule that helps to initiate the inflammatory response are called interferons. Hint, hint, these are small proteins that are released from virus-infected cells. So please be able to differentiate between pyrogens and interferons. Molecules usually diffuse away from the site of invasion through the interstitial tissue, and they usually bind to receptors on the plasma membrane of the unaffected cells. Finally, we have what are called complement proteins. These complement proteins are about roughly 20 of them. They usually lie dormant in the circulatory system, and then whenever you have a lot of antibodies activated, they are activated as well. So whenever a foreign body comes into your system, then the complement system is activated, and it involves, by definition, about 20 plasma proteins that make up this complement protein system, and it helps to stimulate or activate or gouge the inflammatory system as well. All right, moving forward, we have a little bit more of this, and we're going to go forward with this. Before we get a little bit too much into this detail, what I'm going to do is just go over our adaptive immunity, and then we're going to watch a recap video so we can see what these cells look like, okay? Adaptive immunity, as we talked about, is also known as acquired immunity. It's our body's own immune system defense, and this is enacted when we have an antigen that makes it through the defense system. It functions in two forms mainly, and it has many key players, but mainly T cells and B cells are what we need to be reminded of or inform ourselves of. And these reside within our tonsillar tissue, lymph nodes, spleen, and interstitial lymphoid tissue. So as we talked about before, our adaptive immunity is broken down into two parts. You have active acquired immunity, where immunity is gained by actively engaging with the antigen via invasion or vaccination. So the person is either you get a cold and you get that virus in your body and your body makes antibodies, or you get a vaccine where you get to that antigen from the virus and your body is forced to make antibodies as a result. So a COVID vaccine is a great example of this. Passive immunity, as we talked about, is where, by definition, you have immunity gained by receiving antibodies made outside or outside the body by another person, animal, or recombinant DNA. So remember here, we have our antibodies that are housed. An example of this is antibodies housed in our mother that has a fetus. Fetus is born. Fetus now is using breast milk, and these antibodies are transferred from the breast milk to the baby. Now the baby has these antibodies, and the baby can now fight on a cellular level whatever pathogen is within their environment. These are usually short-lived. Sometimes they can grow these antibodies in a lab through animals, or they can acquire the antibodies from animals as well. Recombinant DNA is when they manufacture these antibodies in the lab, and then they poke the patient, and it is injected through the bloodstream. All right. Immunity across the lifespan is super important. Before we go through this, we're actually going to watch a recap video and make sure that you guys understand this and that there is no ambiguity. So we are going to stop talking for a little bit, and we're going to just look at the type of immune responses that we have in our body. You guys are going to be, I think it will help you a little bit. And that way you can keep things clear in your mind. This also is reflected in NCLEX, so that also helps you as well. Okay, so let me know if you guys can hear and if you can see, and we should be good. Oh.
In the last video, we talked a little bit about the immune system. And in that video, we focused on the non-specific or the innate immune system. So let me write that. Non-specific immune system. And even in the non-specific immune system, we subdivided that into kind of the first line, kind of barriers. And those were things like the skin or the stomach acid or the acidity of the oils on the outside of your skin. These are just natural barriers to not allowing things inside of your body. But then once they get in, so you can almost imagine these were the first line of defense. And then you had your second line of defense, but these are still non-specific. And when we say non-specific, it means that they don't necessarily know what type of virus, what type of protein, what type of bacteria. They just know that this thing looks shady. Let me eat it up. Let me kill it. Let me have an inflammatory response. So in there, we said, well, there's an inflammatory response, which I'm actually going to do. I'm going to talk about after we do videos on the specific immune system. You have your inflammatory response, which really just gets things to where the action is at. And then you also have your phagocytes, which are these things, these cells that are engulfing things. Phagocytes. And just so you know, all the phagocytes that we talked about in the last video, these are all instances of white blood cells or leukocytes. So these are all, maybe I'll write that in white. These phagocytes right here, these are all, when I talk about dendritic cells and macrophages and neutrophils, these were all white blood cells. These weren't all the kinds of white blood cells. We're about to talk about more. And sometimes the other word for white blood cell is also leukocyte. Leukocyte. So that is non-specific. It just said, well, one, it just doesn't let you in. But then when you're in, it says, hey, you're just shady. I'm going to eat you up. I have receptors. You have some double-stranded DNA floating around. Only viruses have double-stranded DNA. I'm going to eat you up. I don't know what type of virus you are. I don't know if I've seen you before or not. That's why it's non-specific. Now, the really interesting thing about our immune system, and this non-specific, this is kind of this exists across many species and types of organisms. But the specific is kind of it's thought to be a newer adaptation. What I'm going to talk about is the specific immune system that's particular to humans. So you have your specific immune system. That's our other classification. Let me do it like that. So then you have your specific, or you can imagine it's an adaptive immune system. So, and yeah, I think you've probably heard of things like that. Oh, I have a resistance to that bacteria or that virus. So this is adaptive. And it's really all based on having exposure to things. And within the specific immune system, we talked when we talked about the antigen presenting molecules that the phagocytes do, that plays a role in this. We're going to go into more detail, but I don't want to confuse you. But the main actors here are called the lymphocytes, not to be confused with leukocytes, because they still are leukocytes. So let me write this down. Lymphocytes. So these are the main actors. Lymphocytes, and I want these are specific. Phagocytes, for the most part, are non-specific, but both of these are all white blood cells. Lymphocytes are another type of white blood cell or a leukocyte. Don't want to confuse you with this convoluted diagram, but I just want to make the terminology clear. When someone talks about a white blood cell, they're really just talking about a set of cells that when people first tried to separate the components of red blood cells that would kind of settle in the bottom. Then you'd have this layer of white frothy stuff in the middle that was really made of white blood cells. And then on the top, you had the fluid, the plasma from your blood, the kind of the watery part. So that's where the name came from. But they have different roles, but they interact with each other. Now, lymphocytes can be divided into B lymphocytes, usually referred to as B cells, and T lymphocytes. And you say, wait, where do those words B and T lymphocytes? And the B and T just come from where they're developed. B lymphocytes were first recognized in the bursa of Fabricius. That's why it's called B. That's actually a part of birds that participate in the immune system. And so the B came from bursa. But B also applies to the human immune system because it's produced in bone marrow. So that might be an easier way to remember. It's produced in bone marrow. It's developed in bone marrow. But historically the B came from the bursa of Fabricius, just in case you want to know. But it's easy to remember the B could also stand for bone marrow because that's where it produced. T lymphocytes actually do start off in the bone marrow, but they mature and become what they are in the thymus. So that's where the T comes from. T for thymus. Now in this video, I'm going to focus just on the B lymphocytes because frankly, if I focused on everything, it would be an hour-long video. But the B lymphocytes, frankly, on some level, I don't want to pick and choose favorites, but for something in my brain, I just really like the B lymphocytes. So the B lymphocytes participate in what's called the humoral response. Humoral, and I'll tell you what humoral means in a second. Humoral doesn't mean it's funny. Humoral response. Humoral response, and you'll see that T lymphocytes participate in what's called the cell-mediated response. And we're going to do that in a future video. Cell-mediated response. And they actually do certain classes of T lymphocytes. We'll see that there are helper T cells, and there are cytotoxic T cells. I know it's all very confusing the first time you see it. But that's why I just want to focus on just this part right here. We're going to see in the future that the helper T cells play a role in amplifying and really activating this humoral response. But a simple way to think about the difference between the humoral response and the cell-mediated response is when I get infected, let's say I get infected by a virus, right? Let's say, let's say that's my body cell and that's my body cell. At first, when a virus comes into my system, it's just floating around in the fluids in my system. And that when the fluids of our system, that's really what humoral responds to, into the humoral fluids of your body. So you have your viruses. Let me do it in a different color. These are little viruses floating around. So while they're floating around and they're not sitting inside of cells, when they're not sitting inside of cells, that's where the humoral response can come into play. Same thing if we have little bacteria floating around and they haven't infiltrated cells yet, they're just floating around in the fluid, then the humoral response can be useful for that. Now, if all of a sudden these guys have infiltrated cells, if they've infiltrated cells, so if the cells are now infected with the virus and they're producing, the virus is using the mechanisms of the cell to produce more, then all of a sudden we have to be a little bit more sophisticated in how we deal with these cells and how we deal with the viruses, because they're not just going to be floating around anymore. We probably want to just kill this cell, even though it was one of our own, but now it's helping to make viruses, or maybe it's been colonized by bacteria. So in either case, you want to kill this, and that we'll talk more about that in the cell-mediated.
All right, ladies and gentlemen, so that should be a great recap video. You guys should be able to view this on your own leisure just for comprehension and to make sure that you understand this material. If you have any questions or comments, please let me know. Otherwise, we'll continue forward. I hope you guys are all paying attention. I hope you're engaging in this in some way, but please be mindful that this is important. No surprises on your exam. We've covered this material in class, okay? And this is reiterated by your study guide and your Kahoots. Immunity across lifespan is actually super important. Our immune system is chronically developing, and it's always developing from birth through newborn, through life, through infancy, and through adolescence, and then eventually stabilizes into our adulthood. At birth, our innate and adaptive immunity is kind of not fully developed. It doesn't happen. Remember, our hint IgG antibodies cross the blood placenta barrier, and it kind of stays present for about 3 to 6 months after birth. When we are a newborn, we respond to protein antigens, but we don't really respond to all of them. So things like glycoprotein and polysaccharides that are very common in very common bacteria is what we do not have the ability to fight off. So, for example, Staphylococcus aureus or Pseudomonas are very common bacteria that are usually lie on our skin, and they also lie in our environment. And in any given adolescent or adult, they would be readily available to fight this off, but in newborns, this part of their immune system is not activated and doesn't take place until 6 to 9 months after birth. So 6 to 9 months is when their bodies start to fight off glycoproteins, and then at 12 to 24 months, a newborn or a neonate's immune system responds to what are called polysaccharides. In the infant level or infant activity, we have what's called opsonic activity, and this is where the complement system actually then takes place. Phagocytosis is still not working at this stage, but then the babies or infants move into adolescence, and they develop physical barriers, and they also have immunology changes like hormones. And then their skin ends up thickening and producing a lot of oil and sebum and even more acid to repel all of these organisms. And this is what kind of helps to gouge and solidify the immune system's activity. B cells also are enacted, as well as macrophages. The hypersensitivity reaction There are a few of them. So we have basically when our body malfunctions or when our immune system malfunctions, this is a reaction to some stimuli that our body cannot handle. So we have what's called an exaggerated hypersensitivity, hypersensitivity type 1, type 2, type 3, and type 4, as well as a misdirection, which is autoimmunity, and then diminution, which is immunodeficiency. These things are the things that we kind of need to keep clear within our head from a definitional aspect as well as in general. It's very important to make sure that we have comparative in our study guide. So you guys have a hint in your study guide. Make sure how you differentiate these things. So if you look at a type 1 hypersensitivity reaction, this is where you have a prevalence of IgE. By a general standard, these things are kind of differentiated in the time that elapses for the cells to take full activity. So in a type 1 hypersensitivity, you usually have onset of change within a cellular level within 1 hour, and anaphylaxis is adapted. In a type 2 hypersensitivity, you have IgG or IgM antibodies, which take place over hours to days. And you can have an example of hemolytic anemia. And then type 3 is where you have your immune complexes that are inactivated. This happens from 1 to 3 weeks after your body is exposed to whatever irritant or degeneration is taking place. So serum sickness, hint, is one thing that is mentioned on your test, or lupus is a great example of a type 3 hypersensitivity reaction. And then finally, we have a type 4, which takes days to weeks to take place, and it is predominated by T cells in general. And whenever you have something like Sjogren's syndrome, or you have a rash, this is exemplified by a type 4 hypersensitivity. If you look at these two videos that are embedded in your lecture notes, you're going to see a comparative for these two things. So again, we're not going to watch this in class because it takes up a lot of time, but you do have them at your disposal, and it gives you a clear-cut, precise way to visualize the differences. So do compare that to your study guide and make sure that you know what the differences are between these two systems. Hypersensitivity reaction, you have, again, in table 2-4, an overview of what takes place during those reactions. Type 1, type 2, type 3, type 4, whether it's IgE mediated, cytotoxic, immune complex mediated, or cellular, it kind of tells you in this table. It also tells you what examples are and then the duration of onset and when these things usually take place. So please be mindful of that. Quick knowledge check. Which of the following hypersensitivity reaction can be treated with the administration of epinephrine? Hint, this is kind of an important concept. Type 1 reactions are AKA anaphylactic reactions. In these anaphylactic reactions, your airway constricts, your patient can't breathe, and it's really hard to relax the constriction. So an intervention is needed. That intervention is epinephrine, and that in turn relaxes the airway, opens it up, and allows your patient to breathe properly. Transplantation is something else that your textbook covers and is also on your exam. Whenever you have a transplantation within your patient, you have to make sure that your tissues are matching and they are suitable for each individual. We have 4 types of transplant tissues: allogenic, syngeneic, autologous, and xenogenic. And we need to know the definitions and how these are different from one another, or how they're differentiated. Allogenic transplants, these are tissues that come from the same species. So for example, a Homo sapien, like a monkey, and then a human. The species are not identical, but they're very, very similar. And these are, most transplants, whenever they are transplanted, are usually allogenic tissues, or between 2 different humans is another example of it. Syngenic is when you have identical twins as a host. So twin A gives some tissue to twin B. Autologous is where you have a host and the donor are the same person. So these are kind of interesting to see. Here the patient is growing their own tissue. They have what are called tissue expanders that are implemented under the skin, and the skin grows to accommodate that device that is very uncomfortable. Sometimes people even grow, like an extra nose or an extra part or an extra, I wouldn't say organ, but an extra part of skin or flap of skin on their face or their forehead or their cheek or something. So the skin is actually matched from the individual person. And then finally, we have what are called xenogenic tissues. These tissues are from another species. They usually come from either porcine or bovine, which is cow or pig. The easiest way to think about this are valves, heart valves. Whenever they're doing heart transplantations, these things are imparted into humans, and we can have a smooth transition of use for vasculature, use for easy heart repairs. Transplant reactions can happen as well. So sometimes the transplantation is not always successful for whatever reason. And we have two main forms of transplant reactions. These are hints. So hint, hint, we have what's called a host versus graft rejection, and then we also have what's called a graft versus host rejection. So in the host versus graft rejection, you have three forms: the acute, the hyperacute, acute, as well as chronic, and that again correlates to the time of onset. And then we also have what's called the graft versus host rejection, which varies. Basically, you have donor T cells in the graft that kind of proliferate, and then it ends up attacking the recipient tissue, and that's a type 4 hypersensitivity. So this table is actually really good. Questions may or may not be pulled from it, so hint into that as well. Moving forward, based on the classifications for our immunity levels, we have what's called autoimmunity, as we talked about briefly in a few slides prior. Autoimmunity is defined by about 80 diseases or so. Some of these diseases include lupus, inflammatory bowel disease, which comprises of both Crohn's disease and ulcerative colitis. We have type 1 diabetes, mellitus, as well as rheumatoid arthritis. And we also have the body's normal reaction. So here, basically, your own body is eating itself. Your immune system thinks that your own cells are detrimental to itself, and it kind of starts to try and sequester it. So some of your cells don't work properly. There are many causes for this, like genetics, environmental triggers, as well as defective regulation on a cellular level, and sometimes even tissue injury can cause these things to happen. So the first disorder, systemic lupus erythematosus, or AKA SLE by abbreviation, is where you have chronic inflammation that can affect connective tissue in your body. So for whatever reason, your B cells are activated within your body. They start producing autoantibodies or autoantigens that kind of combine and form what are called immune complexes, and that degrades the body at various system levels. In table 2-6, you have common manifestations of SLE, and they usually affect all body parts, especially the joints, the muscles, the kidneys, the lungs, the heart, the blood vessels. Patient feels chronic pain, which is, all over their body. When it's localized to their joints, you have arthralgia. They may be swollen, painful joints. Characteristically, SLE patients present with what's called a butterfly rash. on their cheeks and over their nose, or it could be on their actual body. They'll also exhibit photosensitivity, so they'll have a shyness to bright lights, or bright lights will cause them to wince or close their eyes. Whenever they're exposed to sun, it will be much, much worse. They'll have ulcers in their mouth. They'll have a loss of their hair. They will have muscle pain. They will have inflammation everywhere, even in the pericardial sac. So the sac that encases the heart, it becomes swollen or irritated, and can rub against, the tissues can rub against one another. These patients also have what's called Raynaud's phenomenon. So that's called the red, white, and blue syndrome, because they have what are called periodic vasospasms and constriction within the fingers and the toes, and it has severe pain throughout their entire body. They have narrowing of that vasculature, so their blood doesn't shunt to the periphery, and they have various levels of decreased perfusion. So your hand should be normally pink in color. People with SLE or Raynaud's, they have patches of white that show the narrowing of the vasculature, and then the blue is the ischemic part where they're not getting oxygen to the distal parts of their body, especially in their fingers and their toes. They might have anemia, they might have bone marrow disorders, they might have lymphadenopathy and splenomegaly. Treatment for this is usually symptomatic. It's usually allocated towards stress reduction or exercise or sleep, or even NSAIDs like ibuprofen or some form of ibuprofen like Advil or Motrin. Corticoids can also be used, corticosteroids can also be used widely for SLE. What it does is it curtails the inflammation, and it also dulls out the immune system, so your body doesn't have a constant attack on itself. Be mindful of the clinical presentation for lupus. This is a question that comes up very often, hint, hint, on your tests and on future exams. For immunodeficiency, we talked about immunodeficiency lightly. It is, by definition, the diminished or absence of an immune response which makes your body prone to infections. You have primary and secondary forms of immunodeficiencies, which kind of, when it's primary, means that it's either genetic or congenital abnormalities. You have people that have asplenia, or if they have severe congenital neutropenia or low neutrophils, then this is when they can exhibit a primary form of an immunodeficiency. Secondary would be an acquired infection or viral or some medical cause that just happened by chance as a secondary result due to some medication treatment. Corticosteroids or chemotherapy can throw your patient into an immunodeficient state. Things like HIV would be an example of viral acquisition that threw your patient into immunodeficient state as well. Opportunistic infections, usually promote your patient having some type of negative onset, like a recurrent candiditis, where they have recurrent yeast infections where their body normally would treat this, but because in an immunodeficient state, they're so devastated or tarnished by whatever is causing their immune system to be dulled out, their body can no longer fight the most common illnesses or common toxins that will affect their body. Kaposi sarcoma, usually associated with HIV patients. Here their cells just form abnormally, and they mutate abnormally as well. And then infections often arise that can just simply result from the normal bacterial flora on their skin. So kind of devastating. Your textbook also talks about HIV/AIDS. AIDS is an acronym for acquired immunodeficiency syndrome. It's usually sexually transmitted, and it is through the acquisition of the HIV virus, which is a retrovirus. There are 3 forms of this HIV process. We have immunodeficiency, autoimmunity, and then neurologic dysfunction, and this is the way it progresses. Once the patient is usually infected with HIV, they may or may not present with symptoms, so it's kind of hard to tell. If they do present with symptoms initially, they will have what are called flu-like symptoms, which comprise of your headache, your malaise, your lymphadenopathy, and this in itself is referred to as acute retroviral syndrome. We have this lovely video that walks you through the progression of AIDS and how it, progresses. So please watch that at your leisure. We don't want to take up too much time in here. Basically, patients can remain asymptomatic for many, many years until they start feeling pain, like ongoing long-term pain. This pain and discomfort, as well as the excess, they have other symptoms as well, like lymphadenopathy, diarrhea, as well as weight loss, and then fever and cough and shortness of breath. But whenever their CD4 cells are actually destroyed, this is usually, when they're destroyed to a certain level, this is when your patient usually exhibits symptoms that they can't bear with. So just note that your HIV levels correlate with your CD4 levels. Hint, hint, that's another thing we need to talk about. And then symptoms usually worsen over a 10-year period. Here you can look at table 2-8. This kind of gives you a classification of how HIV/AIDS is broken down into category, which parallels its severity. So category 1 is when you have CD4 cell count that is greater than or equal to 500 cells per millimeter cubed. Category 2, CD4 cell count is usually 200 to 499 cells per millimeter cube. And then category 3, CD cell count is less than 200 cells per millimeter cubed. And this will progress with all of the symptoms as well that kind of worsen and debilitate the patient over time. Just as AIDS are prevalent within the adult population, within kids around the world, it's even worse. We still, as of 2019, we have roughly 1.8 million children that live with HIV in general. Only about 53% of them actually achieve some form of treatment. And a lot of them, unfortunately, are in developing countries like Africa and sub-Saharan Africa and different parts of sometimes India and other third world countries, which we won't draw attention to, but we'll just say it's super devastating. With that being said, children get this from their parents when their parents don't know that they're transmitting this. So unprotected sex is usually the driver of this outcome, this negative outcome. And clinically, we see the deficit in our patients. Even though we don't know they have HIV, we can still see the factors that are associated with it. So difficulty in weight gain, difficulty growing normally, having trouble walking, mental developmental delays, or developmental delays is how we abbreviate or term it. And then the severe forms of childhood illnesses. While kids are prone to getting sick often, but if they have very, very many outcomes like excessive otitis media, where they have ear infections, pneumonia, tonsillitis, these are the 3 main things that are very common. And if it's exacerbated in a child, you can, you might want to test them for HIV/AIDS. All right. Finally, developing a strong immune system is super important. We have what are called memory cells within our body that retain the antigens, like some form of memory for antigen identification based on whatever we're exposed to in our environment. So like every single thing that we have in our life, we acclimate to our environment. So certain things that we have in our environment, we will, develop a resistance to it. However, whenever we go outside of our comfort zone or outside of our normal living environment, we're plagued by these things. And in an effort to minimize the negative outcomes that will drive our system into disease and, devastation later on, we need to strengthen our immune system if we can within our own life. A lot of this deals with lifestyle changes. So smoking cessation, or stop smoking, eating properly, regularly exercising every single day, or at least at a minimum of 3 days per week, maintaining a healthy weight, moderately consuming alcohol, and then managing stress as well as vaccination are all things that are aimed towards strengthening our immune system. Last but not least, we have this video that's a 20-minute video. This is how to decipher ABGs. So it helps you look at ABGs and tells you how to get these questions right every single time. It does require memorization, and it's not very far from what I told you in class, but if you need to see it in a tangible form, this is exactly what you should look towards. If you do have questions beyond that, feel free to email me or let me know. This concludes our lecture number 2, ladies and gentlemen. I hope that you got all of the questions that come up through your study guide in front of you. If you have other questions, do let me know. Otherwise, I will let you go. I will give time back and give you that time back so you can go and do whatever you need to do. Next week is going to be our last week before we have our exam number 1, so please be mindful of that. You need Respondus browser, lockdown browser, to be inactivated on a stable computer, whether it's a desktop or a laptop, whether it's a Mac or a Windows operating system. It doesn't matter. Just make sure that it's active and working, okay? If you have any questions or comments, please let me know. Otherwise, have a great week. It was a pleasure. I hope that you guys are learning something, and I hope that these Kahoot reviews are beneficial for you. So take care, stay safe, and enjoy the rest of your week. Thank you. Bye.
Is there a code word?
There's no code word for today, okay? Only in selected weeks. So we have 1, 4, 7, and week 10.
Okay.
Okay? All right. No worries. Yes, sir.
If I need the PowerPoint, with like this, because I have it in PDF, where can I find it?
Yes, so the PowerPoint, you guys can convert the PDF to a PowerPoint, and I sent it in your link with your lecture notes. You can also convert it to Word, so whichever way you want to do that, use that link that I sent you in the email, okay?
All right, thank you.
All right, no worries, take care. All right, everybody else good? Okay, have a great week, everyone. Stay safe, bye.